So which one am I functioning off of yours?
Yeah, this one, yeah. This I'll be watching on YouTube.
So I can do these work?
Yeah. Yep.
Okay. The up and down or the side to side?
I'm not sure. I know I was doing up and down.
Okay.
You can try it.
So high tech.
Yeah, it's up and down, not side to side. It won't work. Okay. All right, everyone. Let's get started. Just remind everyone that we are broadcasting on YouTube. We're now live, so please don't discuss any patient names or any of that confidential information. Welcome to SWOC, and thank you for coming. Just to go over a couple announcements. At the end of today, you can get continuing ed if you want. If it takes an hour to do this, you'll get 1 continuing ed. If it takes 2 hours to go through everything, you'll get 2 continuing eds, all for $5. So, couple announcements. Next month we are going to be meeting on, I have this all written down, it's the second Tuesday of the month of April, and we're going to be learning about SLED or KCI's Veriflow, which is their inpatient wound vac now. It's the kind where they, oh yeah, it just plugs back in.
I didn't know which one it was.
There we go. Sorry, we had a little technical difficulty there. So we're going to learn about Veriflow, and that will be broadcasted on YouTube. We have a couple of different options of where you can watch it. You can come here, and it's going to be on YouTube, and there's going to be a vendor here, and they're going to provide a meal. The other option is you can go to Swedish in Seattle, and that's where it's going to be broadcasting from. That's where it's going to be live. But because it's on Swedish property, we're not allowed to have outside vendors provide food, so you have to bring your own dinner if you want to stay in Seattle for it. Yeah, great. Or you can stay at home and watch on YouTube. So it's whatever works for you, and you can have your ice cream and your cat and your dog and everything. So, and then May, we're also going to have SWOC, second Thursday of the month, and that's still to be announced. We're working on finalizing the speakers. So
next week, next month,
mm-hmm.
the
second Tuesday. I'm sorry, Thursday. Second Thursday. It's always the second Thursday of the month.
Second Thursday of the month would be April 11th.
Then it's on April 11th. Yep.
Okay.
So April 11th for next month on SWOC. Any other announcements that anybody wants to make? SWOC related? No. Okay, never mind. Okay, so I'm going to turn the time over to Sally so she can introduce herself, and we'll start our presentation.
I feel like I'm a lounge singer now for our next tune for karaoke. I'm Sally Munn. I'm a physical therapist and a wound specialist, and I work at the Swedish Wound Healing Center with Deborah. And when she was looking for a topic, I said, sure, I'll give it a go. And so we decided to talk about arterial wounds, arterial disease. Now, this is real basic stuff that we're going over. And so also looking for a little bit of discussion about what we see and what we do. And I found I do a lot of education for physical therapists, PT students, and nurses. And a lot of times, even the basic stuff that we put up, and when you see something visually, people are like, oh, yeah, I remember that. So I hope it's not too simple. And then we've got a few case studies as well. So let's see if I can figure out how to make it move. There we go. So as always, I had to list some objectives. So there's our objectives: being able to identify arterial wounds, subjective feedback that would lead us to think a patient has arterial insufficiency, and become appropriate with the appropriate medications for medical management of peripheral artery disease. I guess I better talk slow if I'm going to get an hour. So I think we all know and have seen patients with arterial insufficiency. And I know early on when I was working with patients like this that I would see it at what was then Providence in Seattle, now Swedish, I would always wonder why the doctors just couldn't fix it. And I think we've become used to fixing so many things that we think you can just fix some things. And unfortunately, sometimes we can't. And so as I've worked in wound care longer and gotten a better understanding of arterial disease, I realize how complex it is, because usually these are not folks who just have one problem. It's not like they just have arterial disease. There's a number of other things that's going to accompany that. So I think the first thing I wanted to talk about was what are some of the comorbidities that people are going to have, and what are we going to see with arterial disease. And I put tobacco use first because that truly is one of the biggest factors in arterial disease. And one of our vascular surgeons, who's been a surgeon for probably 40 years, early on one time I was in the room with him, and he said, "Mrs. Jones, when did you stop smoking?" And she said, "Well, I never really smoked, but, I did smoke for maybe 25 years back in my 20s, back to, 20 to 40. And when we left the room, I said to him, always, meaning, are they always smokers? And he said, unless they have some other disease, 99% of the people with arterial insufficiency have been smokers, and the other 1% are liars. So he truly believed that you're going to always have smoking as an issue. And I think that's one of the reasons in the wound registry, one of the things that a good wound management program or a good wound center has is discussion on tobacco cessation and smoking cessation. So if we ever get to the point that we're being surveyed and we're all together in some United Wound Association, we really need to be addressing that tobacco use. And so it is a standard question that we ask people every time they come in, whether they smoke and how much they smoke, and trying to help them, and whether they're on medication or they're thinking about quitting. We really need to do that. And we now have posters hanging in the clinic, the good smoking ones that show all of the bad side effects from smoking. It's pretty interesting. A lot of the family members who come in, you've got the pregnant daughter sitting there looking at the fetus in the womb, and they're saying, oh wow, I really didn't know it was that bad. So we've only known smoking is bad since, when did it go on the package? Anybody have an idea? Went on the package in 1958, I want to say. Yes, most all of our entire lives it has been on the package. So anyway, enough about smoking. Obviously, diabetes is up there, and then the other coronary diseases, hypertension, carotid disease, all are our peripheral artery problems. So again, I put up a picture to talk about what we see with coronary artery disease, peripheral artery disease, and these are cartoons that I've picked off of various places. None of them are my original art. This is a program I am doing for free and not charging, making no money for, as a little aside. So I think it's really important that we remember that what happens is the buildup in the plaque in those vessels. Whether it's in the heart or in the extremities, you get that narrowing of the vessel. And I think one of the things we struggle with all the time when we're talking with people about whether a person can be compressed or not, and God bless our wound nurses who are educated certainly here at the University of Washington, it all comes down to the ABI and how you're going to cut off a person's circulation if you put compression on when they have arterial insufficiency. And I like to put this slide up that actually shows the arteries in this person in the x-ray. And I think the ones in the pelvis are a little fainter, but you can see them. Certainly the ones in the foot you can. You're not supposed to see vessels on normal x-ray, right? They are supposed to be invisible. So both of these people have arterial disease. They both have hardening of the arteries. And I can tell you, as the vascular surgeons have said to me, Sally, you're never going to compress that vein, those arteries in that person's leg hard enough to cut off their circulation. So we don't worry about kind of the gross circulation. Now, do we worry about the microcirculation? Absolutely. If they don't have good circulation on their ankles or their feet, we want to watch out for that. But I think when we're doing compression, we're not worried about kind of the grand picture, because we cannot put enough pressure on those calcified arteries to make that much of a difference. And then here's another picture to remember that we can get narrowing of the vessels way up in our pelvis, and I think that's something we forget as well, that they can be way up in those iliac arteries. And I will tell you, the strangest thing I had probably seen as far as arterial bypasses is a woman who had an ilio biopsy from one iliac to the other, and something had happened and the vessel was actually on the outside, and it was like a Dacron vessel, and her daughter was a nurse, and I'm like, what? And she said, well, I told my mom this probably wasn't how it was supposed to be, and I think it worked its way out. I don't even know how it happened. And so they went to repair it, and she was like in her 90s. I'm like, you sure you want to repair that? Yeah, we want to repair it, and it was not successful. But they do, you know, iliac to iliac. They've got to get by that plaque. So it's the picture shows where the vessel is narrowed and where the blood is not getting through. And again, very important. I know we all say we know it, but kind of visually to see. And I put in a picture of what the stents look like. As the Heart and Vascular Center for Swedish, we see an awful lot of folks who have arterial work done on them. And this very clearly shows the normal flow and then the decreased flow because of the narrowing, and then the stents that get put in. And this one is kind of like, I call it almost an umbrella. It goes in and then pushes against the vessel wall and gives us enough room to get the blood flow through. Now, the other part that's very important to remember on that, which again, I didn't have any clue to, is that stent may or may not stay there for any length of time. So they put the stent in, and we'll talk to the doctors afterwards, and they're like, yeah, get him healed as quick as you can, because I'm not sure it's going to stay there. So it could stay there for days, it can stay there for weeks, months, or it can be non-functioning within 24 hours, which again, I had no idea. I thought it was good. I thought they put them in and they stay there, but they're not always functioning the best. Just stays there? It just collapses. Yeah, it just collapses. Right, it can't, and I don't know why, you know, I don't know the whole why of it, but you know, I'm sure it's, you know, something with the pressure in the vessel and the pressure of the walls and how calcified they are. But we've had a lot of doctors say, you know, do whatever you can now, right? So that's when the person comes in and we're going to, you know, really put the, you know, maybe do the wound vac in non-weight bearing and Regranics, you know, whatever we can throw on them to get it to close. Because they'll say it's a limited window of opportunity. And we see it a lot with people who already have pretty high amputations, and they don't want to have to go back in to amputate again. Yeah. Good, we learned something new. I feel better already. So more cartoons to show pictures of what that actual bypass graft looks like. And again, I know kind of basic stuff, but the bypass is actually just that. They sew in and above and below the blockage in order to get the blood flow done. And the picture here is of the FemPop, I think, is a usual. And in the heyday at Providence, long ago, or Swedish, they had what we termed the fem far away. And so they'd start in the middle of the femoral artery and go all the way down to the most distal part of the tibia, and doing bypasses trying to get blood to people's feet because there's so much blockage in between. So it really is kind of amazing when you think of it, that somebody said, hey, I know, let's cut people open and sew new pipes in. But that's what they do. And then here's just graphic picture of the FemPop graft, the open graft. I'll tell you, we rarely see these anymore because they usually go in segmentally. But in the old days, they'd be filleted all the way up to the top. And that certainly is the most beautiful surgical incision I think I have ever seen. Maybe in my days as a PT, walking people around on the unit, I saw that. But much more of the time, this is what we see. And this is one of our patients that we're currently seeing now. I cropped the picture like this because this is his other leg. Up until 2 years ago, he had about 2 He had nothing wrong. He had been a smoker. They moved up here to retire. This is a pretty high above knee amputation. He has a TMA on the right side. He had a graft in that hole. That was one of his bypass grafts that got infected. And then the sutures are his second bypass graft, which is is it a cadaver? Or is it a... They had a cadaver and now they put a bovine in. So this is truly limb salvage, right? Trying to make it so this gentleman has a leg. And his goal is he bought a beautiful house with a view and the master bedroom is upstairs. And his goal, without putting a lift on the stairs or without putting an elevator in, is to be able to go up and sleep in his bed upstairs. And a lot of work ahead of him for us to be able to get him there. All right, so on to kind of the ulcers and what we see. I think we all know the characteristics. Didn't I hear somebody just tested? Who just tested? Didn't someone test around here and pass? Congratulations. You did pass, right? That's all right. Well, these are kind of the standard of the dry and punched out, painful, usually more distal, and maybe over the bony prominences. And I think, again, this is where we talk about it's not just one thing. Right? Very few people just have arterial disease. You've got arterial disease, you've got diabetes, maybe you've got some kind of autoimmune thing going on. And so it's really putting all the pieces together, but certainly the arterial ulcers do have that more punched out, usually round versus our venous ulcers that we see. Well, so the question is, Katie uses this for education, this picture, and said, what do we think of the betadine on the third and fifth? The fifth has a black toenail. Anyone have any thoughts on that? Come on, wound specialists.
I also don't like the fact that it's covered with fluff and it's not as sharp. But yeah, usually when I see them punched out like that, it's definitely a punched out lesion, but usually I don't see fluff.
Yeah, and it's hard to tell from that photo too. I mean, I think the world is very notorious for not cleaning things off before they take photos. And so who knows, if you go at it, it's just going to lift right, you're going to be able to scoop that out. So my view on the toes is a couple of things. I don't know why we why health professionals have an aversion to washing people's feet. And so I'm not sure that betadine on his toes, not from, 2 weeks ago when he had something done. That is like my pet peeve. Our folks come in, I'm like, wash their foot off, for God's sakes. Nobody needs to be yellow for that long. And then maybe somebody, he could have something there.
I'm just curious.
And the black toenail, toenails, again, everybody's obsessed about toenails. We have to remember anytime you hit, you can hit a toenail. I don't know how many people have come into our clinic and asked for, I want the toenail fungus medicine. And our erstwhile nurse practitioner, well, a lot of times it's damage to those toenails and there's nothing we can do about it. And the medication that you need to, you would have to take if it were fungus is enough that it might kill you. So let's worry about bigger pictures, like you don't have a leg on the other side versus toenails. All right, so talking about the telltale signs of arterial insufficiency when you're working with patients, if you're in the field or even in the wound center and you're wanting to know, these are the things that we certainly look at, is dependent rubor, the pallor on elevation. We're talking about intermittent claudication and rest pain. So I could not find a better picture of dependent rubor if I tried. Right, so dependent rubor, you're sitting at the side of the bed, you have the patient's leg up on the bed, you drop it to the side and it turns beet red. Pretty self-explanatory. And then this one's the opposite direction. When you elevate, you can see those feet are elevated up. One is kind of a normal, healthy color, and one has lost its color on the pallor on elevation. So we will use those. All of our patients have the opportunity to be on beds in our clinic. So a lot of times we'll have them on the bed and start messing around with their legs while we're evaluating and seeing what's going on. We also look at the capillary refill, see if they're getting blood distally. So I thought we would talk about intermittent claudication a little bit, because again, this graphic shows very well when you're looking at the disease and where the lesion is and how they're going to present. So this is just a little cartoon that shows the level that the symptoms of claudication are usually manifest by the muscle group below the hemodynamically significant lesion. And remembering that the reason the muscle group hurts is because it's not getting enough blood. Pretty simple, but I liked that photo because it kind of gives us the region and then the vessels underneath it where they might be blocked up. And then here's another one that's not as clear, but talks again a little bit about where you're going to have the obstruction and where you're going to feel the pain, usually. And then here's one more that shows it a little more graphically too, looking at the usual muscle involved in claudication in the calf, showing where your lesion is, kind of in that distal femoral artery. And I think that also shows to us why, you can, angiogenesis is possible. We've found that you can walk and you can improve your collateral circulation. So sometimes we have people who have pulses, they have pulses in their feet, but they have claudication in their calf, and we find out that they've got narrowing further up in their thigh. And this may be my favorite slide of all time for rest pain. So usually it's in the foot or the calf. Might be when they're reclined. The original slide said something about it being elevated, and sometimes it's just being almost flat and they still can't tolerate it. And we're not talking about Charlie horses, and it goes away when it dangles. And these are the exact questions that I ask people when they come in as we're kind of futzing around. I said, oh, well, you got that wound on your leg. Do you have pain at night that it makes it difficult for you to sleep? Well, I don't know. I've never been a very good sleeper. Do you have to get up at night and walk around the house? Well, honey, everybody has to get up to go to the bathroom. I'm like, okay. I said, are you able to keep your legs in bed with you at night? And I'll tell you, the person who usually answers that question is the spouse. They're like, oh, no, he's always hanging his foot out the side. And that's where you get it. And I thought this was a fabulous picture to show the rest pain, right? And all of these problems are you don't have good enough circulation. Your muscles are being deprived oxygen. So you've got to do something to get the blood down there. The other thing I think when you come to wound patients is wound patients pretty much always seem to think they're always supposed to elevate. And so when we've got our arterial patients who are saying, well, I've been trying to elevate like everybody tells me, and we're like, no, you know what, if you're comfortable hanging your leg down, you go right ahead to get that blood down there. But I think they get kind of stuck that elevation is the way that they're going to get better. And I would say the other, going back to our claudication picture. So I will talk. So claudication is, pain on walking, and the other question I'll ask our folks is, were you able to walk in here today? And we had one guy, from the door? Yeah. You mean from your door? No, from, like, were you able to walk in from the parking lot? The parking lot, I could never walk that far. Well, why can't you? And then you get into the why you can't walk, right? Well, I can't breathe, I can't do whatever. And, then you get to the bottom of if they have, well, did your leg hurt? Did you have pain in your calf that you couldn't make it in? Oh, I can't go more than a block, honey, without having pain in my calf. So those are kind of all the signs that we look at when we're talking to folks to see if they have arterial problems. So talking generally about treatment planning, we want to provide a moist wound environment. And then it's a lot about removing pressure, right? Because we know they're not getting circulation, so we want to keep them out of the tight shoes, get heels off the bed. get them to stop laterally rotating. And if anyone has the cure for the lateral malleolus arterial wound, I'd like to hear it now because it'll save us a lot of trouble. But we have lots of folks who come in, they're in bed most of the time, they rotate their foot out, that ankle bone's resting on the bed, or they sleep on that side. And I don't know about you, but those are like the worst thing to get better. And we do have our first case study is about working with an ulcer in that way, ulcer there. And I put in there gentle compression because the research really does show even some gentle compression is okay with arterial disease if you have some swelling. And so you really need to be mindful of how you do it and what you put on. We use a lot of compression in our clinic. But for someone who has arterial insufficiency or someone we're worried about their arterial flow and we still want to do compression, we may start out with just cast padding and co-band just to give them a little bit of squeeze. And that little bit of squeeze is also sensory. It helps them helps the autonomic and sensory system to remember, oh, I've got a leg down there and we need to get the blood flowing. And if you can get a little bit of swelling out, sometimes you also can get a little more function. If we get a little more function and they're walking, maybe we get the muscle pump to work and maybe we can, get a little more vessel return. And then facilitate a vascular referral. And I know for us, it's pretty easy. We pick up a phone and call and talk to them, and we can get our patients in. But if you're somewhere where you can't, you just have to work, as best you can to report what you're seeing and the reasons that you think they need that referral to try to get them in, because they may or may not have something that's amenable to surgery or to intervention. But you want somebody at least to put their eyes on them and say, we can or we can't do anything, because that's going to give you a better idea of treatment-wise where you're going to go down the line. And as I've talked about already, encourage walking as tolerated because we can promote angiogenesis. So we'll put people on little walking programs. How much can you walk around the house, or can you walk at the mall or the supermarket? The supermarket's good because if they don't use a walker or anything, they can push on the cart, or somewhere where there's benches so they can rest trying to walk a little bit further every day. And I think that also helps people feel as though they are actively working towards a solution. So Deborah is up next to review the next 2 slides. So I will hand her the funny karaoke microphone.
We're playing jump rope with all the cords here. And I'm just going to put this on hold for a second. I want to get rid of this. Hang on a second. I'm going to... Okay, perfect. I think that's going to fix our problem for the YouTube people. Okay, so hopefully that works. Okay. I've got 2 screens going. All right, so let's get started on medical management. So even though nurses, even though we don't prescribe the medications for it, and we're more focused on the dressing changes and the lifestyle changes, there are medications that are used to help manage peripheral arterial disease. And you as the nurse can look at, oh good, yeah, I'm looking at YouTube, it's working, okay. We needed that for the second part of this when Sally gets back up. So there's some things that you can definitely do and work with and advocate for the patient. So the first thing is nicotine. That nicotine is absolutely horrible. I'm sure we all know that as nurses. But that having nicotine in your system is significantly reduces or significantly increases the likelihood of an amputation and a death from peripheral arterial disease. And so getting your patients to either get onto a nicotine cessation treatment program or to just get them off of nicotine altogether is very important. How many of you have had patients who say, you say, are you smoking still? And they go, oh no, I'm vaping. You guys ever had anyone do that? Yeah, I'm seeing some hands. That's great that they're vaping because it means they're no longer getting the tar in their lungs, but they still have the nicotine, and that's the biggest issue. We got to get them off the nicotine. so that we can help them to heal and get rid of the problem, because it's the underlying cause of the peripheral arterial disease. And then the second thing is with their diabetes. Now, just a couple things that I found in the wound ostomy continence's textbook. It says that for each 1% that increases on their A1C, there's a 28% increase risk of death. So that's really huge. These patients need to get their A1Cs under control. Your role as the nurse would be to either advocate for them or try to get them back in to see their PCP to get under better treatment, or just troubleshooting what their barrier is to using their medications. Are they not taking their metformin like once a day rather than twice a day? Are they leery of needles? Do they believe that having insulin is a sign of failure on their part? Maybe they can't change how they feel, but it's going to make a big difference if they're going to lose their limb. And then, of course, patients with diabetes are 10 times more likely to progress to critical limb ischemia and amputation than someone who does not have diabetes. And so these are the two really big things for medications that they need to get on their diabetes medicines or stop the nicotine. Now, those are the two things. I put here amputation off to the side in blue, and when I made this, and then when I put it into the computer, it moved everything around. But that amputation was supposed to be next to the nicotine and the diabetes. Those are the two things that are going to make the biggest difference on amputation. Now, the other things, taking care of their high cholesterol and their hypertension, those things haven't been shown to make a difference in whether or not they're going to lose their limb to amputation or if it's going to cause their death. But these medications are considered essential elements of care because it impacts everything that's going on in their body. So your patients, if they have a peripheral arterial disease, look at their medication list. They need to be on a statin. And if they're not, that's when you want to call the PCP and say, why is this patient not on a statin? Or at least, can we get them on a statin while we're trying to heal this and try to work with them? A lot of the patients, particularly that are elderly, may be coming off of those medications because they have too many side effects. Maybe it's more palliative, and so you're not going to do that. And that's okay. But you definitely look to see if they have that. And then if they have high blood pressure, they need to be on blood pressure medication. Now, when I was preparing this slide, I was just going off of my memory, and I initially put under hypertension ACE inhibitors. How many of you remember being taught that people with peripheral arterial disease, you have to use an ACE inhibitor because you don't want to use the other blood pressure medications because they believed it would make their peripheral arterial disease worse? Well, starting back in 2006, that's all changed. They have some new guidelines. Both the wound ostomy continence textbook no longer says ACE inhibitors, and neither does the American Heart Association or all those other heart people. They say you can use any kind of blood pressure medicine you want on these patients. So the important thing is that you got their blood pressure down to normal, not whether or not, which kinds of blood pressure medicine. And so then the other thing is the other treatment that you should check your patients to see if they're on is either a baby aspirin or something called Plavix. Those are the two drugs that they've done the research on. These two drugs, they are recommended to reduce the death for patients with symptomatic PID. And remember, all of our patients who have a peripheral arterial or an arterial ulcer have symptomatic PID. So just as a rule of thumb, every single time you see a patient who has an ulcer like this, look at their medication sheet. Are they on some sort of a blood thinner? Now, the research only is for aspirin and Plavix, but warfarin's going to help too. So improve the blood flow going through those tiny blood vessels. So check to see if they're on one of those. Check to see if they're on a blood pressure medicine. If they're high blood pressure, see if you can get them back on something, and check to see if they're on a statin, because we need to get their cholesterol down. Those things are going to help just overall with their whole cardiac status. So, any questions about that? Okay. And then for surgery, I was starting to work on some surgical information for you guys, but there's a lot of factors that go into it. But the thing you need to know is when to refer your patient for management of peripheral arterial disease. So, when they have an ulcer. Just because they have ulcers that are arterial doesn't mean they need to be revascularized. Like Sally said at the beginning, you know, we're so used to there's a problem, we need to fix it, and we need to fix it now, because if we don't, you know, something bad's going to happen. If they have a peripheral arterial ulcer and you're doing moist wound healing, there's no infection, and they're on their medications, and you're seeing granulation tissue growing in there and epithelialization, then they're healing. It's great. They're not going to do surgery on them. But if they have a wound that is not healing to these three treatments, then something's going on, and then you're going to definitely need to get them to see a vascular surgeon. And then if the patient has what's called critical limb ischemia, you also need to talk to the PCP about getting them referred to a vascular surgeon. And to help define this, you need to have three things for critical limb ischemia. You need to have ischemic rest pain. So Sally was talking about how, you know, when the patient's walking, they have pain. As soon as they stop and they're letting their legs dangle, they no longer have pain. So they're not critical. They do have some peripheral arterial, but they still have enough blood flow. And then, of course, a non-healing ulcer. If the ulcer is healing, then they're getting enough blood flow. But if it's not healing, meaning the measurements are staying the same or it's getting bigger, then it's a problem. And then, of course, gangrene. So if they have those three things, then you want to get into vascular. So, I mean, you can always get a patient in to see vascular sooner rather than later. But if you haven't met these criteria and you send the patient into the vascular, they're probably not going to do surgery. So try not to be too disappointed, because that's what they don't want to operate on if they don't have to. So, any questions about that before I pass the phone back on to? Oh, yes.
Oh, in the previous slide.
Oh, the previous slide?
Yeah, so would be would you recommend referral to HBO versus surgery?
Oh, so the question is, when would you use HBO for these patients, or recommend it? Oh, versus surgery. So the current guidelines don't say that HBO or hyperbaric oxygen is beneficial in these patients. It's not. That's what the guidelines say. It's not an indication. When I've worked with, I've had a couple patients who I was like, okay, what else are we going to do because they're losing their limb? When I talk to the hyperbarics people, they require that the patient has been seen the vascular surgeon. They've been able to reverse whatever they can, and then the patient also has to be on blood pressure medicine, an aspirin or warfarin. They need to be on a statin. They need to do all these things first, and then they'll consider it. And even then they still have to talk to the insurance and see if they'll pay for it.
Oh, probably not.
Right. So so for those on YouTube, the nurse said, yeah, probably not. And you're right. I've actually never been able to get a patient in for this with this indication. So. Okay, Sally.
I think the other thing to remember too on HBO is there's the indications for it. And one of the things they're going to do is do the oxygen challenge. When you refer a patient to HBO, if they're all qualified, then they're going to put them in a mask, give them 100% oxygen, and check the TCPO2 in the wound. And that TCPO2 in the wound has to go up in order for them to be a patient who can have HBO. And if it's somebody who's got a big blockage, you're not gonna get a raise in the TCPO2 because the oxygen can't get through. All right, so I've got a couple of case studies. This first one's a little bit better prepared than the second. This is a gentleman who was referred to us with a wound on his lateral malleolus. He was in the Philippines, and he fell and broke his, I believe he fell and broke his hip. And he said, when I fell, I think I threw my leg across the room and I hit it on the wall, and that's how I must have gotten this wound. Okay, all right, we'll see. He came to us in October of last year. He complained of ankle pain, worse when he weight bared on the area, and of course he rests. He's one of these guys who rests in external rotation, so he's on that ankle bone. And he likes to sleep on his back or on his left side, and lo and behold, it is his left lateral malleolus. And as I said, if anybody has the idea on how to heal these fabulously, give me a shout, because these are real boogers to get better. He walks without pain, and he sleeps in the bed without needing to get up, secondary to the pain. But again, he said, well, I'm not sure because I get up a lot at night to go to the bathroom anyway, right? So he can't sort that out. So we saw him in the beginning of October. We've got he has a history of diabetes and hypertension. I should have checked his medications. I'm sure Deborah has, but he's on what he needs to be. And the first time we saw him, it was, one by one, essentially. That wound base was boggy. It was firm when probed, so we kind of felt we were getting down to the bone. He had a faintly palpable monophasic pulse, but in his posterior tibia was palpable and biphasic, and his sensation was diminished. So we're saying it's a pressure ulcer, likely from positioning, complicated by diabetes with likely arterial insufficiency. But we said, okay, we haven't done anything. He hadn't done anything to get it better at all, so we'll go with moist wound healing. So we did a variety of things, sharp debridement and moist care. We used Santal to get it redder, and we've used Regranics and pressure reduction. We like to cut bolsters out of things, so we cut some foam bolsters that we taped it to him so that when he went on his side, he wouldn't sleep on it. We looked at his shoe to make sure his shoe wasn't putting pressure on it, and it didn't seem to be, and told him if it hurts, don't do that. Don't do it. And we did do cast padding and Coban, and we had him using his own 15 to 20 millimeter stockings. So you can see it's kind of getting a little bit better. That was October. Here we are in December. But not really progressing as expected. Andy, touchdown, Applegraph. Yeah, still wasn't doing what we wanted. So we did this. We had the arterial study done, and lo and behold, he had a lower ABI, certainly below 0.9, diffuse, mild to severe. I don't even know, stenoleptic. That was the doctor. I don't know what that was from. CFA to trifurcation with the peroneal arterial occlusion, right? So he has disease. Venous ultrasound at this office today, no significant superficial or deep venous. So the vascular, this is from the doctor, left ankle ulcer almost healed, mild arterial hypofusion, no venous insufficiency, given slow but persistent healing and diffuse arterial disease, recommend continued wound care and secondary risk reduction. If he regresses, then wound would consider angiogram and endovascular revascularization. So right now, he's still not healed. There's a picture from the last time he was in. It is a little pinpoint hole. There's still a little depth under there. He's doing Regranics at home just with a dry dressing, and he's following up with us every 2 weeks because he really doesn't want to have any kind of surgery anyway. So we're keeping pressure off of it. It's not limiting his mobility unless he puts pressure on it. So thoughts, ideas about our poor guy? Who's going to cure him for us? Because it's kind of a pain.
I just saw a hospice patient the other day who's also an external rotator, a little bit of trauma, and now she's got a wound.
Yeah, sharing again that external rotators with trauma resting on their ankle bones. Anybody else? Now I think it's 0.2, 0.3. It's small, so very, very, very slow. Not anymore, I don't think. There was, but not anymore.
I have a question. So another doctor asked me about this too. How much do you do breed week to week because you're laying down such full term week to week? Like you just do one breed and kind of just keep it.
So Andy's question is about how much debridement we do. I think for this gentleman, we're going to get him a little bit red every time he comes in. We're not tremendously aggressive all the time. And then, as we're getting down to this picture at the bottom, from the February 27th, if the edges start to roll in, if you get that epibole, you're going to bring those back because there's no way it's going to heal unless he wants to have a pierced ankle. Then we can probably facilitate that. But so we are going to do gentle stuff all the time. I know some places would be more aggressive than gentle.
Sally, I'm wondering if you put this on onto the speaker, what would you do for a patient
So Deborah was asking what we could do. So we've got someone like this who has this lateral ankle ulcer, and what would be a long-term dressing or a long-term plan. We have a number of them that we've seen. I think if we have a woman who's in her late 90s who lives with her daughter, and that wound has been there for years now, and she's okay with it. You can paint things with betadine to just let them dry out. You can just put protective dry dressings on them. This gal, we have a dressing on. It kind of will scab up a little. They'll come a few months later. The daughter will say, yeah, you want to take that off if the scab falls off. A lot of times there's not even anything under there because she has such poor blood flow and she lives with the chronic wound. I don't know if anyone else has experience of what they do. Other thoughts, Deborah?
Maybe just odor control, if that is an issue.
So Deborah was talking about odor control. If that's an issue, you can keep it clean with the betadine should keep odor down, or you could use some kind of wound cleanser on it, something to protect it. We're hoping that he heals. I think we'll get him there. But I think again we didn't think originally he had as much arterial component as he did, but obviously he has some. So all right, so that's the first one. Now my second one is not as well organized, and this is a lower extremity abscess. This gentleman is 55 years old. He has diabetes, and he was referred to us a couple weeks after this photo was taken. He has a TMA on that side, and he'd noticed for a few weeks, maybe a month, that he was having a lot of pain on his anterior lower leg. He went into his primary care doctor, and they felt around and felt that it was kind of smushy under there, so they assumed it was an abscess. They anesthetized him, the area. They cut it open, and they got 1 liter to 2 liters of fluid out of his leg that was malodorous, pretty stinky, and they sent him to the emergency room for further treatment and admission and antibiotics. He went into the hospital. He was on IV antibiotics. They did cultures before they started the antibiotics. He was seen by ortho. Ortho took him into the OR. They washed it out. Ortho closed it and put an incisional wound vac on top of it. And I will tell you that during that entire time in the initial bit, he did not have any cultured infection. So they were treating him, but there was an infection, and the wound still was not healing. Now, the aside is the patient had a severe football accident in his high school days. He was very unclear as to what it was, but he had to have surgery for it, and he was told in the future he might have a problem and he could lose his leg. Well, it turns out he had had 2 fasciotomies. He had a compartment syndrome, and I believe he had severed one of his arteries, and he had actually had a bypass graft and a repair. But he didn't know that when we were talking to him. So this is after he was in the hospital. So he was followed by ID, and he was referred to the wound center after an ortho follow-up, and ortho said it wasn't healing. And this is kind of the picture that they had when he came in to see us. So there's the 28th. That was his first visit to us. And you can see a week later on the 1st. The 28th was the pre-picture and my post-picture cleaning it out. So everyone along the way was saying, oh, healing well, it's got granulation tissue. And we were reading what they were saying and thinking, it doesn't look so much like that. And I don't think anybody ever poked it with a stick. But we, pushed on it a little bit, pushed on the wound, and more fluid, more kind of brown, yellow fluid started coming out. And I think if you look at his leg, what's the first thing you kind of describing his leg, what's the first thing you're going to use, maybe? I don't know if you guys, look at it, it looks like a piece of wood, right? If that's not one of the kind of, the woody appearance that we all were taught for arterial disease as well. So he did not have palpable pulses. We were willing to kind of give a little go and see if we could get it to heal, but it was not getting better. So we did refer him to for an arterial study, and we referred him for a TCPO2. And I'm sorry it's so small on there, but you can see his lateral ankle was 36, his medial ankle was 63, but his lateral malleolus was 38, and his medial malleolus is 43 on his TCPO2. So we got him into vascular, and in the meantime, you can kind of see that the halo on the January 1st, see where it's really dark, kind of that line of demarcation in the photo, if you can see it halfway up his calf. He came in and it was soggy all the way up there. So we started pushing, and again, more of that fluid is coming out. So what everybody else thought was an abscess is in fact, he was liquefying his tissue from arterial insufficiency. So no one checked his arterial flow, and they were thinking that it was still just this abscess or a sterile abscess. But I am not a physician, never have been one, never have done vascular surgery, but I'm fairly convinced that was happening is when the vascular surgeon went in, she found that bypass graft had failed. So he was not getting any circulation to his legs. So he's gone in, he's had bypass surgery, and he has had a skin graft. We haven't seen him yet. He's still in the hospital, in hopes that he can save his leg. There are conflicting MRIs whether he has osteo in his leg or not. I looked at the op reports, and it doesn't sound like anybody has done anything. When vascular went in, they just revascularized. Then they had plastic surgery, clean the wound, and put the graft on, but there's not a discussion of osteo. And I can't believe he doesn't have osteomyelitis when he had such poor circulation. And you can't see, do I have another photo? Oh, there we are. So you can see it's just getting bigger, and it's yellow down there, and that's really firm. And again, one of the physicians said, "Oh, granulation tissue around the edges." I'm like, okay, that's a fantasy world. And bone is not in base. And I'm like, if that is not the bone in the bottom of that man's wound, I don't know what it is. So we talked to him extensively about the fact that he might need an amputation, and he might end up with a below knee amputation, and he was ready for that. And when we started pushing all that goo out of his leg, when things started getting worse, we called over to vascular and said, "This is getting worse. Do you want to see him?" It was going to be like 2 weeks. Now, the doctor had only seen his report. She hadn't physically seen him. And she said, no, it won't change anything. And in fact, it might not have. But I made sure we were on our opinion that this is happening. It was on record with them, so that we were concerned for him. And it started, he had not had pain, and now it's hurting more. So there's the results from the angiogram on the 20th. That it was an ischemic left lower extremity ulceration. I will say one of the physicians along the way who'd been treating him, we'd kind of been treating in tandem, was pretty insulted that we insisted on an arterial study. He said, "I don't know why you'd do that." So, we'll see. I think, is that the last one? We'll see how he does. So that's kind of our last one on that fellow. And I'm sorry it's not better put together, but I was going through and it got, they go each different direction. So we did try a little gentle compression on him, and he liked it. The other thing that compression is going to do is they don't have to change it as frequently, right? So we put a lot of stuff in there to absorb, put stuff to absorb on top, and then wrap him up, and he doesn't have to worry about it. And as I said, he's already got a TMA on that leg. So my prediction is, if this heals, he maybe gets a couple of years out of it, and hope he doesn't get more sick from it, right? So that is if we go 5 minutes with questions and answers or discussion, we got our hour. Bainbridge Island, way better than looking at arterial wounds.
So you don't know the results
Of what's going to happen for him? She did the bypass. She just did the bypass he's been in the hospital the past 2 weeks, I think, about. They did the bypass maybe a week ago, and they did a skin graft, and he's still I think he's still in the hospital. He lives alone, so the question is can he go home? You know, the other part of it is I'm not sure how good his diabetic control is. We were kind of more set on getting him into the right direction versus, you know, worrying about all the other problems. And I think he still does smoke a little bit. I don't think he's quit all the way. And I know that that's the, you know, the telltale sign. You walk into the room and you're like, sniff, sniff, are you smoking? Oh, no, I don't smoke. I'm like, wow, it really smells like tobacco in here. And one of our physicians, previous physicians who was a rehab doctor, would walk into the room and she was not shy about going, whew, I can barely be in here. This room just stinks of smoke. I don't smoke. Well, you smoke and you're a liar. I mean, she would really let into him about smoking, right? So I think he still does smoke a few cigarettes. So hopefully he can work on that while he's in the hospital. And he knew he should quit, you know, just like anybody else. And I think my one strategy for people smoking when they say that they smoke and they have to smoke is I say, can you wait 15 minutes? Because I think the research shows something. It's 90 minutes from the last puff till your vessels get back to normal after you've been inhaling the tar and nicotine to get you back to where you were. So I'll say, can you wait? Shailene, can you wait 15 minutes? Can you wait 15 more? You know, look at the clock and say, I can wait 10 minutes. I can wait 15. I can wait 30. Because really, if you can just get them to smoke less, right?
So I have my patients kind of track. I don't have them quit like that.
Will this reach over there?
I have them track.
We're going to put you on the YouTube.
All right, here we go. So I have my patients track when they're smoking. I don't say quit right now. So if a patient smokes a pack or two a day, that's really hard to track because that's all they're doing is smoking. But if they don't, they say, you know, at 7 a.m. I get up, I have a cup of coffee, I have a cigarette. I come home at this time, I go out on the porch, I have a cigarette. So now they track it, and they also hit a behavior that is going along with that cigarette. And I don't have them choose their most important cigarette, the cigarette that they love the most. Let's choose a different one. And then I do what you're saying. Let's push that cigarette out to the next one, but now let's replace that behavior. So if you're going out on the porch, you can't go out on the porch because going out on the porch is connected with having the cigarette. You have to do something else. You have to fill that void. And you take it really slow. And these people who smoke a pack or two a day, they need a lot of help. They need their primary care doctors to be involved. They need to be watched because they have to go through, you know, they go through withdrawals, and then there's other types of behavior changes that have to go with it. And there's a lot of anxiety. So, yep, so that's what I do. I don't yell at them.
I really like that idea of their behavior, though, right? This is this is where I have my cigarette, so have it somewhere else. You can't go out on the back porch, go out on the, go walk in the street.
Somewhere else.
Go somewhere else, right? Any other arterial thoughts, arterial ulcers?
Where does he get the skin graft from? And is he still going to take that from the leg if they're having?
I believe he still took I think he probably took something up on probably the other leg.
Like probably really high up.
On the thigh, I'm guessing. He doesn't have so he has, I shouldn't say he doesn't have. We never checked the other leg. He has all of his toes on the other leg. He's not had a problem. He doesn't have claudication. He doesn't have another problem on the other side. It very clearly was this big injury that he had. And it wasn't until one of the residents kind of went through, and I don't know if she got his old history or just sat and talked with him, that we found out. And he has old fasciotomy marks that you can see on the leg further up. But I'm assuming he took it from the other side on the thigh. And I can tell you the worst place, I get really ticked when they take it from the back of the thigh. What are you thinking? How are we going to get that better, right? Now you got this here, and that seems to be yeah. So we'll see how he does. But I think the other part of it is he is ready somewhat to know that he's going to have an amputation. And I think sometimes they're coming down the line, and I think most of the time we kind of associate those amputations more with diabetics, but I think, arterial disease is a progressive disease. As as our fellow who has the above knee on one side and the TMA on the other side. And, you know, he was, aside from, I'm guessing, a history of smoking, and again, he quit long ago. He's really kind of, you know, been the picture of health and active fellow, and it just all caught up with him at once.
Wasn't the second one a diabetic, or was that just the first one?
The first fellow is not diabetic. The second one is.
Okay, so this one that we're seeing is diabetic. Okay.
Yeah, the first fellow was not. The first fellow was probably, as the doctor said, 99.9% a smoker at some point in his life. And unfortunately, I don't think the statistics are very good for, you know, even if you quit, because people are like, well, I haven't smoked for years. And I think the damage is done. I mean, it is a bad deal. I had the pleasure of being raised by a single mother who was a nurse who smoked her first cigarette at 16 years old in the closet at Cooley Dickinson Nursing School nurses' residence in Northampton, Massachusetts, because it was cool. And I am her daughter. She suffered with carrying a little extra weight, and she learned that if she smoked cigarettes, she didn't weigh as much, and she became a dedicated lifelong smoker. And my mother would say, because after, you know, now I know everything because I've been through PT school and I'm a, you know, healthcare professional. Mom, you know, they know that smoking gives you lung cancer. Sally, there are plenty of people who get lung cancer who have never smoked. Okay, Mom. So she went on to smoke. She ended up in a situation where she smoked 4 packs of cigarettes a day, right? She was in a bad home situation, a bad situation, a marriage with a man with a lot of children who moved into our home that she, you know, and couldn't manage. And so I think what happened is, I'm going to do that after I have a cigarette. Right, you're talking about the behaviors. I'm going to do that after I have a cigarette. So at 50, when she was 55 years old, she had lung cancer for the first time. She went on and had 3 heart attacks, bypass surgery, and lung cancer a second time. Still smoking.
But your mom was a nurse back in the 70s and the 80s.
My mom was a nurse in the 40s.
Oh my gosh.
Yeah.
When you're a nurse in that era, if you're going to take a break, you have your cigarette in your hand. Oh, you're smoking. Okay, as soon as you're done with your cigarette.
Yeah, she started and when she was 16, she was in nursing school. So, and then the other thing I would say is, when I first started, I've been a physical therapist for a very long time. Nurses would smoke in the rooms.
Oh yeah.
So I can remember getting patients up. So I'm the PT. We were talking about earlier, Georgina and I were talking about people who are now going to do outpatient surgery, that total knees are now going to be outpatient some places. And, you know, on my first job in the East Coast on the ortho unit, the total hips were in bed for 12 days and the knees were in bed for 5 before they even got up. So it'd be day 12. I'm getting up the patient. I have the puke bucket and the smelling salts, because they're either going to throw up, pass out, or do both. And I can still see Pinky, because of course we only went by our last names. I can still see Pinky and Bish working to make the bed while I'm holding the patient up with cigarettes in their mouths, watching Phil Donahue on TV. So, right? And I'm sure they had hats. And then you'd go into the nurses' station, and it was like a smoke-filled room, including the doctor. You know, there was the doctor's side, and so I followed all these behaviors people were doing, and then I realized they're only doing this because they smoke. I don't smoke. I'm getting out of here. So, I think.
The person I've never argued with that she smoked was 2 cigarettes a day. She's 170.
Still?
No, she was.
She was 107, 2 cigarettes a day.
2 cigarettes a day. No wounds, no nothing.
It's kind of.
Her doctor would go, yeah, I got nothing.
My father-in-law, who has cardiac problems, but he's losing weight. The doctor's like, you can have whatever you want. He said, well, I don't think I should eat ice cream. Oh yeah, eat whatever you want. Doesn't matter. You're good. All right. Well, I am done. Thank you. I hope it was informational and good to share. And as I said, not rocket science, but good things for us all to remember. So thank you so much.
Thank you.
So I had one more question. Some of the people who watched these meetings on YouTube had some questions about long term. What happens if the patient, if we're not going to be able to heal it, and the patient doesn't want to have an amputation? What is the course like? What's going to happen with that patient, and how are you going to manage the symptoms and everything? And I'm seeing, Eugenia, you're shaking your head. Yes, would you like to share an experience of what you did and how, as a nurse, because some of our nurses are rural and they're going to see these things and the patients are going to say, I'm not going to do an amputation.
I am working for a retirement community, and for 15 years I was a wound nurse until last year. I just become just a manager, but do occasional wounds. So in my population, it's a lot, like 65 and older. It's tons of people who have open wounds. They don't heal, or heal. They actually die before the wound heal. So, and what we do, just a basic treatment. We make sure don't have an infection. But again, in a nursing home, lots of time wounds become turned to chronic. Most of them are either pressure ulcers, venous, very occasional. I think I have only 2 arterial ulcers in my experience, but pressure ulcers, like especially occipital, that's a lot. Non-healing wounds. Yeah, just a clean dressing.
So if
sterile.
So that, let's go back to that picture. This patient's wounds here, this guy. If the patient decided, so he's not, let's say he says, I'm not going to have an amputation, I want to die with both my legs intact. What would you expect to see happening?
Me?
Yeah.
So they don't want amputation?
Yeah.
But progressively, but very, very slow deterioration. So, maybe a few weeks ago, one of my patients, she's close to 95 years old, she was doing shopping and the child was playing with a shopping cart and hit her in the leg. So she developed very bad infection, and so it's been maybe 5-6 weeks. And there is no change. Whatever we do, regardless what we do, the doctor offered her below knee amputation. She refused, and that's it. Every single day we change dressings. Seems like lots of drainage, lots of infection on surrounding tissue.
Mm-hmm.
Just basically. Our medical directors are like, okay, just keep it what it is, keep it clean as possible.
Okay, so your treatments then are to keep it clean?
Most of the time it's a palliative.
Daily.
Yes. And again, Medicare doesn't pay for expensive dressings. We either have a home health, which is only very limited amount of visits, or we are doing whatever we have in the house.
And then what kind of dressings you're putting on the outside?
Mepilex. I personally like Mepilex, and we have a lot.
Okay. And then does the patient experience pain as they're going through this process?
Yeah, a lot.
Okay. So
most
then pain
of them.
control would be
if they don't have neuropathy, yeah, they do have pain.
Okay, yeah. And then, of course, odor control. Yeah.
Obviously.
Okay. Seems obvious to you and me, yes, but I just wanted to get it out there because we do have a lot of nurses who wonder, they're going to have patients who refuse the amputation, what are you going to do? And that's what.
But again, in a population over 80 years old,
yeah.
They would probably die on a surgical table versus a lot. Yeah.
And there are limits. Medicare and Medicaid both have limits on what they will provide wound care wise. They're not going to pay the 2-layer compression wraps that the doctors love. Medicaid covers one of those a week, and the wound clinics want them 3 times a week. The foams They won't cover the Meta-Honeys and the alginate. They won't cover, but they'll cover a Meta-Honey colloid. I just found all of this out through Shield, but it's interesting what they will cover and what they won't cover, but they want them healed. Yes. Oh, and they won't charge out normal saline or wound cleanser.
How about wound vac?
Wound vac has to be authorized, and it's the company that does the wound vac for Medicaid is not as good as the former KCI or even the Monlicki one. Yeah. The green foam, sorry.
The green foam, yeah.
I have a comment about when you said something about, the wound center might want one thing and it has to be another. Certainly I can't speak for any place else, but we really try to work with our community providers. So if someone is, giving you an order to do something, you're like, we can't manage that. Certainly if it's us, call and say that, tell them that we can't do that, because what's going to happen is no one's going to take those patients, right? If the demands are too high, whether it's home health or a facility, you're not going to take the patient with that high a demand. But if, we all know our own silo, right? We all know what is covered where we work. So I'm going to make this great dressing plan and give it to you, and you're going to say, we can't do that. We can't use that foam. We can't use that whatever. People will, at least our clinic, will be very flexible with people, and sometimes nurses will call and want the orders more specific. And I'm like, I don't know what you have. I don't know what foam you have. I don't know what alginate you have. I don't, this is what we need to have happen. But I think you need to really work to be a community, right? We need to be a community taking care of these folks.
And oddly enough, the Providence outpatient clinic, all of a sudden the header on all her orders was may substitute
Equivalent.
Oh.
So
We got that on our.
Yeah, so if those on YouTube didn't hear that, put may substitute or equivalent on your orders and stuff like that, and that's very helpful in making sure that your orders are able to be used in all the different settings.
So the conversation that started that was you are aware that Medicaid will only cover one of those. Oh no, are you kidding me? No, I'm not kidding you.
Yeah, so there are a lot of insurance limits for the supplies, and so sometimes you have to work with the patient, and sometimes patients are going to have to pay for it or come up with a real cheap, easy dressing for them. So.
Or in the case of Providence, we have been told foundation.
Yeah.
That's one of the reasons they have.
Yeah. So just to finish up and to recap what Sally was saying. So the big thing with arterial ischemic wounds, several of us, when they were coming into the room, I was hearing them say, these wounds are really frustrating, and I can't get some of them to heal, and so I'm hoping you have some ideas. Well, reality is I think we all have some ideas, but we also need to be willing to accept that ischemic wounds are very difficult sometimes, and some of them won't heal, and that's okay. We're not going to be able to fix every single wound, unfortunately, and then that kind of goes against what we want as nurses. We're helpers, we're fixers, and stuff like that. So I think that's everything. Tune in. Oh no, I'm sorry, I almost forgot. We do have our vendor here at Medline is hosting our meal, so he's got a few minutes on a product that he wants to show. So let me get to that really quickly as I'm going through all this. I'll get that for you, Sally, just a second.
Are you driving the space bar? Is that
Yes.
space bar?
No, the arrows.
There you go. Yeah, so it's up and down arrow right there.
Okay, perfect.
All right.
All right. All right. Thank you guys for having me. My name's Micah McCauley with Medline, Tissue Regeneration Division. I see some familiar faces in here. They call us Corius Tissue Regeneration. It's the Latin word for skin. So we just have two products. Wanted to talk to you tonight about one of them that's called Plurogel. Okay, be more than happy to. I want to be respectful of the 10 minutes that I have here, so I'm going to go fast. I've got a lot of information to tell you. I'm going to go quickly, and I'll show you a lot of pictures on the back end of the presentation as well. So what it's designed to do for you, assist you with healing, debridement, topical debrider, A lot of patients report a reduction in pain, and the providers are able to reduce the amount of pain intervention that they're using. And it's also been shown to prevent and eradicate biofilm formation. I also think it's important to point out to you what it's not. The name Plurogel, a lot of times I think people immediately go to thinking it's a hydrogel. It's not a hydrogel, not a honey. It's not cytotoxic, and it does not cause maceration in the wounds. Very versatile product, a lot of different types of wounds that you can use this in. They're listed here. Since we have an audience on YouTube, I'll say them quickly. Chronic vascular ulcers, venous ulcers, diabetic ulcers.
Oh, they're there.
Light to moderately draining wounds, your first and second degree burns, your partial and full thickness, surgical wounds, trauma wounds, tunneling, and undermining wounds as well. So what's in it? The key ingredients in it are purified water and something called Poloxamer 188. Poloxamer 188 is the primary ingredient, which was initially FDA approved to reduce blood viscosity. It's also been used to reduce aggregation in sickle cell patients and then also improve cell viability. We've got a clinical bibliography with about 21, 22 studies on Poloxamer 188 that I can provide, and each study has a link to it as well. So bottom line, right, what's in it for you as the provider, what's in it for you as the patient? It's different. It's completely different from anything else out there in that it has very unique MOAs, allows you to debride and address biofilm, and it's safe on the face, near the eyes and the mouth as well. Why does it matter, right? Greater patient compliance, it's self-friendly, non-ionic, and non-cytotoxic, and I'll demonstrate results for you, and I'll share some clinician feedback that we received just in the last couple of months with somebody getting at a children's hospital getting started with Plurogel. So what's different about it? The Plurogel is a surfactant, surface acting agent, right? But it's a concentrated surfactant, and that makes it behave completely differently at the molecular level. So it's lowering the tension, right, between two liquids or a liquid and a solid, and then that aggregate of surfactant molecules are micelles. So those micelles, they're very compatible with the lipid bilayer of the human cells, and they have that hydrophilic outer core donating moisture to the wound, hydrophobic inner core, the hydrophilic outer surface, hydrophobic inner core that's helping to trap, it's softening, loosening, and trapping that wound debris. And then I'll show you in a minute, it's 100% water soluble, so it washes right off very easily. But it's about that high concentration, and at the high concentration, those micelles link up and they form a matrix. So then that matrix is constantly expanding and contracting on the molecular level or rinsing the wound on the wound surface. Something very unique about it as well, so it has backwards or inverse thermodynamic properties. So it's going to behave opposite of anything else that you've used before, in that when you put it in a warm wound bed, it will thicken instead of getting thin and runny. Put it in the freezer, you can pour it basically like water. So thickening in that warm wound bed, right, it's designed to keep it where you want it, which is in contact with the wound, prolonged contact with the wound debris. Thin it, you can draw it up. Oh, I'm sorry.
Question. So if you were to put it in the fridge and cool it down, it becomes thin and runny. Does it also take on the coldness? If you were to put it into a wound, it'd be cold for a while?
So for a little bit, it will cool down some. Even at room temp, it's going to be more like a gel or more liquidy, for lack of a scientific term. But you can, when it's thinned, you can draw it up into a syringe, right? Or sometimes they'll pour it over a burn for a soothing effect. Yes?
When it becomes thin, does any of it separate out? Does the ingredient separate out, or does it remain?
No, it remains. So thickening, when it warms, those micelles in there that we were talking about are getting much closer together, and that's what's responsible for the thickening. But no, the components of the Plurogel do not separate. Talked about it being 100% water soluble, right? It should rinse off very, very easily for you. Should be no scrubbing required, reducing pain at dressing change. It's completely biocompatible as well, so you can combine it with antimicrobials. or any anti-infective dressings that you maybe currently prefer to use, you can use it with those. And in Europe, it does contain 1% silver sulfadiazine, not in the US yet. But again, you can compound it with antimicrobials of your choice. So I wanted to talk, I mentioned biofilm earlier, so I wanted to just address that for just a minute. Dr. Schultz, Greg Schultz, and 10 experts from around the world published in 2017 the consensus guidelines for the identification and treatment of biofilms in chronic and non-healing wounds. A few of their key consensus statements, right, were biofilms are present in most chronic wounds, likely to be located on both the surface and in the deeper wound layers. Wound biofilms are difficult to visualize macroscopically. Debridement, of course, being one of the most important treatment strategies against biofilms, but does not remove all biofilm and therefore cannot be used alone. And then that biofilms can reform rapidly, and repeated debridement alone is unlikely to prevent biofilm regrowth. Plurigel is in line with biofilm-based wound management. So there is data. I have the copies of the IWII guidelines, if any of you are interested in them this evening, showing that it can prevent biofilm formation, disrupt biofilm, eradicate mature biofilm, prevent reformation, and then increase antibiotic efficacy as well. In that, if you take these hard copies with you, so page 17 to 19, they did a section on debridement, and they broke out the various types of debriders. So surfactant is the Plurigel, and you can see there where they're citing the studies preventing the biofilm formation, increasing antibiotic efficacy, eradicating mature biofilm, and then preventing the reestablishment of biofilm as well. Our bibliography, there's 7 studies on there as well that you can link to for biofilm data. And then about 2 weeks ago, Dr. Schultz hosted a webinar that we have a recorded link to on biofilm. It's packed, loaded with a lot of really, really good information. I've watched it several times. I learn something every time I watch it. But he discusses sort of winning that war against biofilm. So in terms of why it matters, right, we got feedback, gotten a lot of feedback on Plurigel, but from a children's hospital, a CWN emailed us last month, mid-February, and was talking about using Plurigel. I don't know, can you guys see it? Mm-hmm. Okay, I tried to make it big enough without it getting stretched out and funny looking. Using a teenage oncology patient who was basically refusing all treatment in her perineal and buttocks area, experiencing severe pain, refusing all cares, finally agreed to Plurigel in a small area, and then once the nurse applied it, she reported a drastic reduction in pain, requested that they put it on the rest of her affected spots. And I wanted to show you this to prove the point of it being gentle, being used at a children's hospital, but tend to hear that radiation burns tend to be incredibly difficult to handle and to heal. So it helped this patient a great deal. We're working on a radiation burn here at this facility as well this week. This patient, they've decided since she's been readmitted that they're going to go ahead and use the Plurigel prophylactically. Feedback from the same wound care nurse at the children's hospital, a tiny little one with lesions to the fingers of an immunocompromised infant, very skilled at removing dressings. So we ended up applying Plurigel several times a day before naps and bedtime, using Vaseline gauze to wrap the bandnet gloves to help secure it, and her wounds healed remarkably fast with a significant reduction in her pain and PRN pain med use. And her mother's report, and her mom said the Plurigel was like magic for her daughter. So in both cases, this nurse is saying, and again, they're getting started with the product, but I'm pleased to have something easy to use, not only for the patients, but for the providers as well. Results with Plurigel. So from here, I'll show you just a lot of pictures, but for the 10-minute time sake, I'll keep it moving. Pyoderma, day 1 to day 10.
So it's just put on and cover with whatever you want to cover with?
Correct. I show you application. You can apply moist gauze to it, Curlix. It doesn't have a humectant in it, so it needs to be dressed to keep it covered.
Over it,
Correct. You would apply daily for best results, nickel thick. If you need to go out to every 3rd day, and some pictures you'll see even as only once a week application, you'd go up to 2 nickels thick, just double that layer. In the little one, little neonate here, 15-day-old, 24-week gestation, pediatric fungal necrotic dermatitis. So you can see day 1, day 10, looking pretty good inside of a month. Pediatric burn, we saw this little one earlier. That's day 0 with the scald burn, out to day 11. Another pediatric burn, 2-year-old falling into a fire pit. When they started to put the Plurigel on her, she would just hold her hands out and they would walk in the room. Didn't really say anything, but I think she said enough without saying anything there. Playing with mom's curling iron, burn on the cheek. You can see it week 1, and then the week 6 follow-up. VLUs, so this is day 1 and then out to week 2 and week 4. And this is pretty ideal for sloughy, stalled wounds to get out of the way what's stopping that wound from healing.
Use it all the way through?
I'm not here to tell you have to, that you don't have to use it to complete height. You can. It is, again, non-cytotoxic. It's going after what you want it to go after, and it's not going after the granulation tissue and that kind of thing. Another VLU, day 1 to day 8. And then this one at week 1, beginning to get cleaned up and just getting it ready for what you all deem is the next best step. Yes, ma'am.
Questions. One, can it be used on oral mucosa for people that have stomatitis and stuff?
Okay. So on the face near the eyes and mouth, our medical scientist in demonstrations puts it in his eyes. I haven't done that, but.
Second of all, why does it reduce wound pain? What is it? What mechanism?
So, some theories that I've heard is that just getting that layer on there, and then I've got some I can pass around to you. You can put a little on your hand and literally watch it thicken in 15 or 20 seconds. That it's just, now you have this layer that is kind of helping to stand between that and the environment.
So like a cream that you would put over the wound that kind of keeps it from being open to the movement of the air?
Correct.
So it's not that a severe burn is very painful, and it's not like this actually would make that pain go away. I mean, that would be an
I think that's
overstatement.
what he said, though, because he said the 2-year-old. So if you treated people with Silvagene, right, the minute it goes on, they're like, and then like 5 minutes later it hurts. But it sounds like because of the philic and phobic activity or whatever of the stuff, and it thickens when it's warm, it makes a layer, like a cover.
Right. So and I want to be clear, it does not have a pain reliever in it, no ingredient in it for that. It's just patients tend to report a significant reduction in pain. But it does not have any sort of drug in it that is.
So it would be anecdotally, patients are reporting.
Correct. Yes, consistently.
Which I can see the soothing properties of it, especially in the perineal and rural areas.
Right.
And with babies.
Yep.
You got to know any 2-year-old that says put it on, you know what I mean? Like it had to help that kid.
Oh my gosh.
Otherwise they'd be like, as a teenager, right?
Oh gosh, yes. Best anecdotal I've ever met.
Yeah.
Well,
that's amazing.
Another VLU, right? The comorbidities that you're all dealing with day in and day out, stalled for 10 months, skin subs and compression used previously. CST is concentrated surfactant technology. That's Plurigel. This is a 1 to 2 time per week.
You said something about if it's a nickel thick, how long before you rinse it, wash it off the wound?
So the IFU will tell you daily for best results and do a nickel thick, but if you're going to see that person maybe twice a week, and knowing that it's not realistic to always see your patients every day, go 2 nickels thick. If you're going to see them, say, every 3rd day or 2 times a week, just double it up.
And then you'd just be rinsing it off those 2 times.
Correct. Yep. So they were able to get the 69% reduction by week 7. Pressure ulcer, less than a week. Again, getting that slough out of the way so that can begin to heal. Here's a pediatric pressure injury as well, inside of, so day 1 all the way over to the right to day 13, just getting it cleaned up so you can move that forward. So put it on. You can put it on top of it. Now it will be effective on thin eschar, thick eschar. I don't want to overpromise and tell you it's going to just get rid of all of that. See, providers sometimes will score it if the patient will tolerate it to help it get in there and soften that up, so you can work with it a little bit better. Surgical wounds, dehisced wounds. At presentation week 1, week 3. This is one of the latest papers that was published on Plurigel, late 2018, groin wounds. So a pretty dramatic reduction out toward week 3 and just getting that wound cleaned up. Peripheral vascular disease, smoking, everything that we've been talking about for the last couple of hours. Full thickness trauma on the heel. Got it nice and cleaned up and ready for the next step. Vasculitis, this is going from November to the bottom 2 pictures to March. Wound closure at 12 weeks. Hidradenitis, you can see pictures there. At week 3, 4, week 6, and about week 8. DFUs at presentation week 1, 2, and 3. Tend to see the healing from the outside in. It's home health ulcer on the foot, just shy of a month later. And then a 40% reduction in this non-healing DFU at year 1, after 1 year. And then amputations as well, so week 1 and week 4, and another amputation where you can see diabetes comorbidity, as is typical. I'll wrap up with the basic application notes that we kind of already touched on. Light to moderately draining wounds. If you've got a highly exudative wound, you'll want to get that addressed before putting this on, would be the recommendation. Again, 2 nickels thick, 5 millimeters, if you're going to see them a couple times a week. These are the dressings. Definitely not asking you to do anything out of the ordinary, all things that look familiar, I'm sure, in terms of covering it up. And then removal. Again, it should come off quite easily because it's 100% water soluble. And just use your normal protocols. IFU is going to tell you daily application for best results. Go out to every 3. Change as needed.
Is there a problem with leaving it on more than 3 days?
Some will, in some cases, they'll see the patient only once a week, and you just put it on as about as heavy as you can get it.
It doesn't. There's no contraindication to doing that. You're just not going to get as effective.
Correct. The micelles will sort of they're going to begin to dilute a little bit, I guess, so to speak. Exactly, right. So they're not. It's not going to have the same effect as it would as if you did it 2 or 3 times a week or daily. But again, in certain instances, that's what's realistic, right? And it still works. So I hope I was close to 10 minutes. But no.
How much does it cost?
Okay. Yep. Yep. So a 50-gram tube is usually around $90. It's sold in a 400, usually to burn units, 400-gram jar. We also are getting 20-gram tubes that will be, I think they're going for about $49.
So can I buy I am a patient at home, can I buy it through DME?
The patient can get it from Medline.
From Medline?
Yes. Mm-hmm.
So the patient would just call Medline themselves?
Right, they can order. I can provide you guys information. They can use a certain sort of account number to order it and get pricing on it. It's not a prescription device, no. Not a prescription device. So I know it is pricey compared to sort of the hydrogels and honeys and that kind of thing. I think if you think of it compared to other certain types of debriders, maybe used in the inpatient.
Do you know how much a tube of iodosorb costs?
Good question, because I'm a nurse. This is not something I want to keep in my kit, like in the back of my car. It should be it needs to be in a stable, hot, cold, you mean? Yeah, not too hot, not too cold.
So just, I mean, you would store it at pretty much at like a room temp. I mean, so I have a tube, sometimes if I walk around with it in my pocket right next to me, it will start to thicken up a little bit. If you needed to cool it, sometimes if I'm going into a meeting, I can just put it in a cup of cool water.
Does it damage it for it to get hot and cold?
No.
There you go.
No.
Doesn't damage it.
Thank you all. I appreciate it. Thank you.